right, let's bring the meeting to order. This is the Human Resources Committee meeting that's set to start at 3 o'clock. I'd like to call, I'd like to ask the secretary to take roll silently. I know that Senator Wilhelm is at a bill signing, and she will be joining us in just a bit. Minutes are approved as distributed or printed unless there are other objections. Seeing none, let's move ahead. We're live streaming today's meeting again for our constituents who can't be here. We have DHS staff will kick off and have a presentation where we'll talk about how the Medicaid managed care transition is going so far. We have some representatives from the Attorney General's office here as well, and 3 representatives from the MCOs. So thank you all for taking time to join us and answer our questions today. So I sent you a note beforehand that I said we had questions in certain areas. So the areas today we'd like to cover are provider networks, complex cases, and an escalation procedure, which we'll kind of explain, pharmacy, formularies and prior auth, and Medicaid card, member card. I think we need to get some information out there and make sure people don't throw their Medicaid cards away. Transportation for people with disabilities, and an update on provider billing. We'd like some answers from IME on those, and those topics of concern are shared with you beforehand. So I'd like to make some introductions here. Mikki Stier is our Medicaid director. Jean Slaybaugh is the DHS CFO. Liz Matney is here, Medicaid Managed Care Bureau Chief. And then from the Attorney General's office, you can just wave Eric Tabor and Jeff Thompson from the AG's office, and our MCO representatives today. Thank you for joining us. Kim Foltz, Health Plan Chief Executive Officer from United Healthcare. Cheryl Harding, our Market President, Iowa, AmeriHealth Caritas. Cynthia McDonald, Plan President, AmeriGroup. Again, thank you for joining us. So who would like to kick off an opening statement? Mikki, would you like to start? Director Stier.
Thank you very much again. We do appreciate the opportunity to come before the Senate Human Resources Committee and provide you an update. If there are questions related to some of the topics you talked about, we're going to defer those questions to the individual MCOs because I think they can best answer them. But I'd like to give you a little bit of overall the philosophy towards this implementation was to work to ensure members' needs were met, to recognize any trends, to address those across our system. We are pleased to report that we have not had any major system issues. However, when something this large, of this magnitude, is transitioning, we have met quickly to ensure that the member issues that we are receiving are responded with compassion and resolved as quickly and immediately as possible. Key to that has been our strategy of an implementation of a project management office, aligning that office with the account managers. We have talked before in the past that each one of the MCOs have a dedicated account manager that reports into the state to the project management office. When we went live April 1st, we were receiving information from them every 2 hours. If there were issues, they went directly to the project management office, and we triaged within the state staff as well as within the DHS staff to resolve those issues. Problems that we have tracked in main areas are prior auths, the understanding that existing authorizations will be honored for 90 days. New services would need authorization. All pharmacy needed authorization, and as if you can recall, we started on April 1st, which was a Friday. We did keep our member call centers open, our provider call center open, our medical call center open, and our pharmacy call centers open for the last 2 weekends. As you would figure that many families and members purchase prescriptions on the weekends, we knew that pharmacy and access to those pharmacies over the weekend would be critical to have our member and our pharmacy call lines open to assist those pharmacies with there was questions with the PDLs and ensuring that if there was troubles that we actually had state staff viable to the MCOs to support them during that transition. Happy to report over the weekend we had some volume, but it was, I think the first weekend it was about 557 member calls. No medical calls or pharmacy calls came in on the first weekend. Last weekend we had about 157 calls come in, and again, they didn't access either one of those medical lines for us. Overall, our call centers, our member call center has received over 18,000 calls since we went live. We have an average wait time of 20 seconds, but you can remember that we also beefed that call center up to almost 100-member call center staff with an average of about 4.5 minutes that they were talking on those calls. In addition to that, other issues that we have identified besides pharmacy and prior authorization is transportation. One of the key things that we did the first weekend was that we were having our member services reach out to case managers and confirm transportation. There was a little bit of uncertainty with transportation, knowing that we deferred it to the MCOs for transportation and that warm handover. We wanted to make sure that people knew about transportation. We continue to hear issues about transportation, and we're dealing with those on a day-to-day basis, on an immediate basis. When it comes to complex patient issues and or member issues, we do have an escalated procedure in place. Oftentimes, we reach out to our sisters in the Division of Department of Human Services, the Mental Health Division, as well as our eligibility, and they actually help us wrap around services, and we triage as a team with the MCOs. So those are some of the things that we have done moving forward for the implementation of managed care. And again, we welcome the questions and the opportunity to speak today on behalf of the state and the implementation of managed care.
Thank you, Director Stier. I also want to add that all of the members of our committee received this document. It should have been put on your desk this afternoon. And the information that we requested, you answered all the questions, most of the questions. I think maybe some of you might have some other questions that extend from this. So lists of MCO stakeholder advisory groups, how much more are we spending on managed care? Please provide the contract provision that requires MCOs to abide with any and all laws and regulations. And you provided that. How much has each MCO spent on advertising? Is it possible to expand the eligibility verification system to allow for a provider to check more than 7 members at a time? And how many state and contract full-time employees are currently working for Iowa Medicaid? So that was provided for us, along with a document on the contractual requirements under subsections, and then administrative category definitions for us to understand what was given to us. So thank you for that. I guess I would like to start off the questions. We read an email, a story basically on the floor of the Senate last week about pharmacy. And I think it hit the news, maybe some news stations picked it up. And it was a physician's assistant who was seeing a gentleman who had schizophrenia. He was on an injectable. He came in and he wanted to, get a new prescription. And his MCO that he is connected with now, she had to jump through a lot of hoops. And bottom line is she had to order through a specialty pharmacy in Orlando, Florida. And for that prescription to get here, it was that whole process was going to take about 2 weeks. She was very concerned about the loss of progress with that patient. So when we're talking about managed care, that doesn't really follow along on that managed care theory, right, and that managed care practice. So she was just very upset with the system, and then the response, I believe, from IME or DHS was, well, if there's a situation like that, we should take a patient to the ER. Well, we certainly know if there's an emerging situation, we should go to the ER. But in this case, this is a perfect example of where managed care could succeed, but because of the obstacles, it isn't in this case of this gentleman. So give me a scenario or give me a situation of how we can remedy something like this. Can you tell me what we can do about someone who needs an injectable and it doesn't come for 2 weeks?
Hi. Yes, that was actually a very unfortunate situation. There was some miscommunication by the call center for our PBM. This was an AmeriHealth member. Some miscommunication by the call center and the PBM, and I quickly, as soon as we became aware of that situation, we identified that we had a control in place in our system that should not have been there. That's a standard control, but in a new program, we wouldn't do that because we don't have a specialty pharmacy program at this point in time. So as soon as we became aware of that, we've removed the edit. We communicated to all of our pharmacies how that should happen and that it would still be the normal course of business like it has historically been. And we certainly spent time retraining some of the staff on the call center, which in other established programs, it was the correct information, but not in this program. So we've corrected that. And that's certainly not how we would want that to work.
Thank you for that. I have another question about pre-auth. So an ophthalmologist, an ophthalmology practice was looking at their pre-auth procedures. And two MCOs would allow for, if the doctor was making an examination and needed to do something surgical, they needed to do a check. They needed to go ahead and instead of stopping the examination and going and calling for a pre-auth and maybe shutting down the exam, sending that patient home and bringing them back, two of the MCOs said, go ahead and do it, and one said, no, you're going to have to shut down the exam and you do need to get, pre-authorization. So we're kind of placing a burden, on physicians here where we have three different, ways of doing things. Is there any way that some of your pre-authorization could be more standardized across all three MCOs so that we wouldn't have these kinds of situations? He went on to list several other things about pre-auth that were different in an exam and then going a little bit further in an eye exam. He felt that if you're going to stop the exam, you're going to send somebody home, you're going to bring them back, it actually is more expensive when he assumed that this person was going to have a situation where they needed an MRI. This person is on Medicaid. We don't know if they have transportation back, if they can take the time off from their jobs to come back. There are a lot of different situations that are, again, going to escalate the cost. So is there any way that the managed care organizations can become more standardized with their pre-authorizations, or is this just a rhetorical question that I'm asking?
Well, I think that's a good point. I think the answer is yes. We can take a look at it. I certainly can't speak for the other companies. I know for AmeriGroup, we don't do much, if any, of that prior-authorization component piece for ophthalmology. But I think perhaps to the point in general that we can take a look at that and see. I mean, we're day 12 into the program, and there certainly are some just lift pieces and working through some of the real issues that people are experiencing, the bugs, I guess I would say. Although generally, our very strong view is that things are going well. So, and not unusual in markets as you bring a managed care system in, especially of this magnitude. And so anyway, long answer to yes, we would certainly be interested in taking a look at that.
I do want to commend, when I got home on Thursday, I called one of the managed care organizations. I found out there was an issue with the provider. We called at 8:30 at night. They gathered together by 9 o'clock. They called the CEO of the provider and said, I think we have something worked out. They gathered at 7 o'clock the next morning, worked out a situation, and had an answer to the provider by 9 o'clock. So I'm not going to single you out, but those are the kinds of results that at these initial stages, if we're going to say, that we have issues, that was a really positive thing that happened from that. So, I just want to thank you.
Yeah. One of the tools that we have developed with the department, and it's on our website, we also pushed it out to all of the providers, is, to your point with prior authorizations, is that we actually have a grid, a matrix of all three of the plans with some very key common diagnosis codes or procedures that could be utilized. That matrix is on our website. Again, what we're trying to think of is strategically towards implementation. What are some of those questions? Prior authorization is one of them. How can we address that? This matrix is an easy tool, an initial tool to help actually walk providers through those prior authorizations. In addition to those, there has been a series of informational letters, anything you could imagine that has come up. And when we are going out and meeting with associations, or we hear a common theme, such as transportation or prior auths, we're generating additional informational letters and generating those quickly and then trying to push those out. We have been meeting with associations of every type of provider type in the last week, and also asking them for feedback that we've heard, and then generating from there additional communication that we do need to refine, so that our providers clearly have a clear understanding, and we listen and hear what are some of the unmet needs that we do need to address and continue to refine.
One other thing, and then I need to turn it over here to the committee. A couple of other providers have said that it's difficult to get to some of the, to get to some of the formularies. They said a couple of their nurses in their offices just are having a tough time trying to navigate, and these are experienced people. They've been able to do that, and again, that standardization of the formulary. So I'll gather some information, maybe I can deliver that to your legislative liaisons, and we can take a look at that too, so. Questions?
May I just add
Yes,
a
yes,
comment?
please.
So all of us are required to follow the PDL, the pharmacy drug list that the state's PDL. So in fact, I just checked that this morning on our website to see if we could access it. It's readily accessible. So anyway, there is a standardization to this that we all follow.
Good to know. Questions?
Senator Ball.
Senator Bolcom.
Thank you, Madam Chair. To follow up on your question on prior authorization, I think it does make a lot of sense to have a similar prior authorization done by all three MCOs. I'm wondering, Mikki, if you how that will happen. Will the department work to facilitate bringing the three MCOs together to have that conversation and see if we can get some uniformity in this?
Like the department has in the past, there are several things we've already standardized on, like the universal credentialing form. We already have had discussions with administrative simplification for managed care with the three MCOs. So we'll add this to the list of having that conversation of logically what makes sense to prior authorize and standardize that.
I would expect that providers would be like thrilled with that as a uniform process. A few weeks ago, we had a meeting with your team, Mikki, and Director Palmer, and we asked about the consumers, the Iowans that are on Medicaid today that are extremely vulnerable, frail, high needs beneficiaries, and what steps are being taken to surround those particular people with what they need as we go through this handoff. And we know when the governor closed the two mental health institutes that we had 3 people that were documented that actually died prematurely because they were transferred from a facility that their health care needs were being met, and they were put in other facilities where they weren't able to have their care met, and they passed away, and those stories were well documented. And I don't think there were more than, 130 or 40 people that were moved out of those facilities. Now we're talking about 500,000 Iowans, and I think you've identified several hundred that are extremely vulnerable, and I guess I'm interested today to know how the handoff has gone, or how is it going, and how each of the MCOs is queued up to make sure that those individuals that we know are high needs are being assigned to and overseen by the MCO's personnel, so that provider continuity happens, that the consumers are signed up with the right people, and that the services that they might need, whether it's in the community or in a facility, continue to happen.
So just as you recall, one of the requirements with CMS pre-go live was that we had and Liz can speak a little bit more on this as well, we had to do training of every single case management entity in terms of a transition to the MCOs. We individually reached out to all of those agencies, asked them if they were going to continue in case management with those individuals. If not, we were to transfer them to case management within the MCOs. We have transitioned their files and where those individuals are in terms of case management, and have had multiple trainings and dialogue as a pre-go live requirement from CMS. We attained 100% training of those case management agencies between all three of the MCOs. Each of those MCOs did 100% training of the case management to understand what the requirements were for those case management agencies, to understand what and how to work with each of the MCOs. They were trained by each of the companies on how that warm handoff would occur and happen. That is in place, has been in place. And then with the care coordination that each one of them, and I'll have them speak to how they're operationalizing that warm transfer for them. And then the state, the department, it says, as I said earlier, we have a complex escalation process in place right now, so that if there is an issue with a member, we can immediately get the team around it to support it with that MCO. But I'll let them speak to how that transition has occurred, sir.
So as Director Stier described, we did work very closely with all the case managers and continue to work closely. We have daily fax communications and feedback channels open and remind everybody on a daily basis to make us aware of any issues that are arising. The goal being that all members receive the services they've been getting and that there's no disruption to those services. Additionally, what's available now in the managed care world is for those members, if they need it, and for the rest of the population, we have a complex care process where there's really no wrong door to get into that process. So it can be a case manager notifies us, it comes through the pre-authorization process, it could be the member calling us directly, or the other way that is very effective is we do data mining to identify, and we have the history. So we've already been doing outreach calls to members where we offer them care management services they can choose to participate in. But what happens is that team forms a team with all of our clinicians, including physicians, the members, providers, family members, the member themselves, and to work out a treatment plan that is appropriate for that member if there are gaps or holes. And a lot of that happens with members, for example, that have constant presentation in the emergency rooms or have a high readmission rate after hospitalizations. So we do a lot of outreach to identify those folks and to wrap those services around and to develop those treatment plans to hopefully prevent those issues from reoccurring.
Thank you for the opportunity to be here today. I think you're going to hear a similar theme from the three of us. From United's perspective, our approach is person-centered. And when we received our list of individuals, and you were speaking specifically about those highest risk, our approach is to prioritize those at highest risk and begin that outreach immediately. And so as we received that final list, even days before the program started, we began outreach, working in tandem, in collaboration with a member's existing case manager. If they needed a new case manager, we were doing that outreach to ensure we had all that information. Again, reaching out, having those conversations, scheduling face-to-face visits. So we have already had face-to-face visits with many of those high-risk individuals to ensure that we're evaluating all of their needs. We have identified some that have some additional needs that we have had the opportunity to take that information and get them connected with those additional needs and services for those additional needs. So the approach and the intent is to ensure that we're taking that person-centered approach, understanding the unique needs of each individual. As you heard from my colleague Cheryl, we also have a data mining tool which stratifies members based on that previous and historical claim information. So we're also identifying individuals that may have not previously had services that would qualify or be good candidates for services. So we're engaging individuals that may not have had a case manager before, but now we see that there is an opportunity to get them the resources in order to help them live healthier lives.
And I'll just say it's the joy or the problem of being third, right? It's It's the same. It's the intensity around this, the team approach to the issue or the problem, or bringing in the specialty. I'll add that piece to it, which I'm sure they have as well, which is, for instance, behavioral health cases. We've done several of those, where then the behavioral health team will encircle the member, if you will, with the case management component, and that bring in that high specialty, for instance, in that particular area. So it's also part of our process, but also a specialty component that is added in as needed, depending on the situation. But it's very intense. It's very member-centric. It's a phrase used, but it's very real in our world. That's what the case management core encircles, and it's a very core function of what we do and what we are paid to do. So.
Well, Madam Chair, I appreciated the department's focus on this when we met a few weeks ago before we made the change, and the recognition that there are going to be some people on the program that are going to be extraordinarily vulnerable, and this handoff needed to happen well, and I appreciate your answers this afternoon. Thank you, Madam Chair.
We have Senator Yoakum.
Thank you, Madam Chair. I wanted to go back to the handout you gave us, Director, and have a few more questions about that itself. So I want to start with the advertising, because you did mention that they did tell us how much they spent. AmeriGroup $480,000, which includes production costs. AmeriHealth $450,000, and United Health $74,000. It says in here that the department was not reimbursing MCOs for advertising costs or other expenses prior to April 1. Will they be allowed to take advertising costs out of the 12% administrative overhead and profit margins that we're allowing? Where will that come from this day forward? The cost for advertising.
I can't speak directly for how each of the MCOs handles their financials, but I would assume that those costs are aggregated as startup costs and will be amortized as startup costs over the life of the program.
Okay, so they each may be able to answer that as well when we get over to this. Okay, so let me give you another question then with your handout. You mentioned in here that there are 14 external vendors now. There were 9, so we have 5 new external vendors with managed care, and that we're still anticipating that it's still going to save us money, even though we have hired 5 additional external vendors. So I'm trying to figure out how we're going to save more money when we hired 5 more external vendors. It does say it's going to be offset by anticipated changes in medical contracts, expenditures, and anticipated changes in federal financial participation. So my question is, how much savings from the anticipated changes in federal financial participation? I know that our amount of money for the Medicaid program is declining a little bit, and the federal reimbursement rates are going to be higher. So tell me what that is.
We don't know the exact changes in federal financial participation yet. CMS has been reviewing and updating its approaches to matching administrative costs. So for the last couple of years, as we have contract amendments in our administrative contracts, we go through a negotiation process with CMS. So for administrative costs, the match can range anywhere from 50% to 90%. And we negotiate with them as we negotiate amendments to our administrative contracts.
So could you provide me with the details on how you provided us with this answer in the handout then?
Certainly.
We could have some more detail on it. I would appreciate that. Let's see. All 3 managed care organizations, I guess I'll turn them to MCOs. Each of you have said that you are setting up stakeholder advisory committees for your first meetings. Could you provide us with the names of those people that are on your stakeholder advisory now and their contact information? It says the day that you're going to have your first meeting, but where will that meeting be and what time? AmeriGroup says May 19th. AmeriHealth is saying May 24th. United Health is saying May 11th. It's going to be your first stakeholder advisory committee meeting. So who are your stakeholders, and where and what time will those meetings be held? And let's see if I have anything else on this page. We have listed on the last page 470 contracted staff, including 99 temporary ramp-up call center staff. So if I take out the 99 temps, so we've still got 369 contracted staff. What are the contracted staff doing for the department, for IME, on this page? We asked for how many employees are still with IME to provide oversight, et cetera, of the system. Implementation, contracted staff. So there's 399 contracted staff, if you exclude the call center staff. What are those contracted staff? Who are they? Is this including the 14 vendors, or what do you mean by this?
So the 14 vendors, just to correct you, just a correction on that, if you will, please, is
Okay.
that, right, we have had 9 vendors all along.
Right.
Okay?
Yep.
So we've added 5 new ones
Yep.
that will provide some oversight for managed care. That contracted staff are those staff. So it is
So
the
I want to know.
intelligence staff, it is the Myers and Stoffers, who's the rate setting and provider cost audit, it is the pharmacy call center that we talked about. That is that contracted staff. It is those professional contracted staff within those vendors.
Okay, that's what I want to know. Just want to clarify that
That-
that's what was the vendors,
Yeah.
the 14 vendors. Okay, great. This is a question for the department itself. There's a Drug Utilization Review Commission, and in October, there's 9 members. I believe it's 5 with a doctorate in pharmacology, 4 medical doctors, and up until October, there was cancer treatment medications and medications for HIV that did not require prior authorization. Now they do, starting January 1. I'm getting calls from oncologists and others who are saying that that is creating considerable problems, that when someone comes in and is diagnosed with cancer, delaying treatment for a prior authorization can be very troublesome and worrisome, because many times they need to get treatment going ASAP. And now we're requiring prior auth for those medications that we never did before. So I'd like to have an explanation on why that came about. It was something we never did before, even though we could have, but we never did it before.
I will go back and speak with the DUR commission that actually made that recommendation and implemented those changes. and
You
get
know,
your
I'm a
rates.
bit skeptical, because this came right before our supposed first launch date of January 1. And these changes became effective January 1. So I would appreciate it,
Yeah.
because I truly am getting calls from oncologists, and I do not have a good answer. Okay. Do I need to stop? I have lots of questions. I don't know how many other senators have questions. So I can stop and come back. I'll come back then. That's fine.
Senator Johnson?
Thank you, Madam Chair, and I would ask for your indulgence here to talk a little bit about transportation, which is an important issue in the rural area. Well, I mean, just anywhere. I've received another contact from a Center for People with Disabilities, and you know, in wake of the Olmsted decision, of course, clients there are working in the community. So this was a call that went into an out-of-state call center in another state. I said that, but out-of-state, so that she could get to her job at McDonald's. Okay. We assisted her in calling, as there was no way she could navigate the system by herself. And these are non-medical, but just, you know, I think this might be an example of again, think both non-medical and medical calls that have to be made. There was a lot of introductory information when we reached the number. If this is a medical emergency, call 911. If this is mental health emergency, press 2. Hours of the call center. If scheduling a ride, you must call 48 hours in advance. And after 3 minutes and 10 seconds, we finally spoke to an agent. It took 11 more minutes to schedule the ride, as we had to provide the following: member name, member ID number, name of caller, relationship of caller to member, caller's phone number, pickup site, complete address, including street address, city, state, zip, pickup site, phone number, pickup date and time, destination site name, and complete address. destination phone number, return trip, pickup date and time, final destination name and complete address, destination phone number, additional passengers, if any, accompanying members, special assistance necessary, wheelchair, walker, scooter, oxygen, so on. The agent asked a couple of times if this was a medical appointment. I responded no each time. The member works at McDonald's, and we are requesting rides for her to go to and from work. The second time, the agent wanted confirmation if this ride was to Dr. McDonald's. Okay. So we received a call, we completed the request for rides, and then we're told that we would contact a provider in this area, and we would hear back from them if the ride was confirmed. Total call time, 14 minutes, 35 seconds to get one disabled person to work. On Monday, we received a call from the Rides office, and Spencer Rides is our regional transit authority, indicating that the rides we had requested had been denied because the person who called in the rides was not an approved agent for the member. Rides was told by the broker that a friend could not call in the request for rides. The member's case manager would have to call in the request. Can you imagine all members calling their case managers calling the MCO's transportation broker, the broker calling rides or another transportation provider, because there's only one available in this area, and then wait for that provider to contact us. At a transportation meeting a week ago, sponsored by the Regional Transit Authority, an MCO representative said, "We are here to make your job easier." So we're just going to talk about this. Now, getting back to this same center, my understanding is, as of yesterday, United Health is letting them contact directly the Regional Transit Authority and arrange rides so that there's no broker. AmeriHealth has agreed to do the same. I'm here to encourage AmeriGroup to get on board with this. AmeriGroup has not agreed to let this Center for People with Disabilities contract or contact directly the Regional Transit Authority so that groups of people can even be assisted in getting dropped off at their jobs if they're going shopping or whatever. So that's one thing that I want to make clear. The center also let me know that all three of the MCOs are letting their clients, at this point at least, keep their case managers, which they appreciate very much. So I just wanted to make that point about that. It's very, I'm hoping we work all this out. This is a non-medical call, okay? And she wasn't going to Dr. McDonald's. So that's all I have to say. I don't know if there's a response from AmeriGroup about this, but I think that this, we've got to be a little bit more flexible than using these brokers out there.
Please.
So on behalf of AmeriGroup, we will take a look at that. Our goal is to make it as easy as possible. We do use Logisticare as our entity. They do a number of our state businesses across the country, and so, but it also is my job, our job, to ensure that we don't, we try to eliminate as much of the bureaucracy as we can. It could be an initial setup of a file that we want to make sure we're meeting the needs of a member, but in terms of that direct access, I hear the point, and I will personally take a look at that.
I expect an answer next week then, that you've agreed to let Village Northwest Unlimited and any other centers for people with disabilities be able to continue their relationships if they already have them with the regional transit authorities, if you would, please. Thank you.
Thank you, Senator. Senator Peterson.
Thanks, and thanks for letting me join in today. I have a question for each of the MCOs related to how you're handling legal guardians of Iowans. I've heard a number of complaints of people who had already informed the state that they're legal guardians of the patient, and that information did not transfer. Now they're having issues with that. So maybe if you could touch base on that for us from each of your groups.
So if the information, we're looking for the information in the enrollment records that we receive from the state. We also do now have access to the state's system, it's called IMPA, that has that guardian information in there. So if we don't automatically see it in the file, we'll go search there to see if we can identify it. We'll look to all of those sources that have been given to us access from the state, so we can ensure that we're contacting and verifying that information correctly.
Thank you. Same answer for AmeriHealth. We originally did not have access to those systems, but within a few days of implementation, we were able to set up every one of our call center members with access to the system so that we can look that up. So that shouldn't be a continuing problem at all.
So you just received access recently to that information, so that was a glitch in the transition that's been fixed? Is that what you're trying to say?
Yeah, I want to say it was the first or second day of implementation, we had that. Part of the challenge was we put a lot of procedures in place. I'm probably true for all of us, let the others say if they disagree, but we put procedures in place to ensure we're not talking inappropriately to members as part of our HIPAA security, and that's where the challenge came. We quickly recognized that. We worked with DHS, and all of us got access and were able to set our teams up.
Okay, so I think we're covered then.
That's the same, yeah.
Okay. My next question is for Mikki. You've talked about a warm transfer multiple times. You use the term warm transfer, and I tell you, I'm still getting letters from people who would call it anything but a warm transfer. One of my constituents had a dermatologist appointment scheduled on April 1st for skin cancer, and had reached out in advance because she hadn't gotten her card, had not gotten her number yet, went ahead to go to the appointment because it was her understanding she'd be able to keep the same doctor for at least 90 days as part of the transition. And I believe that's what you said all along, you'd be able to keep your doctor for a set amount of days after the transition. Is that correct?
There was an appointment to the physician, yeah, they were to keep those appointments
Okay.
because those questions. And if
Okay.
there was prior auth for those care, absolutely.
Okay, so this woman had gone to the same doctor for 10 years, goes to the appointment to have skin cancer removed, and they told her she would have to pay cash. Can you explain that to me?
It depends, okay, and I believe are you speaking about an issue with a major provider? Some of the providers may choose not to participate if that's the issue, or if those providers needed additional information. I believe we addressed that issue, and that individual did receive the care as soon as we became aware of it.
So that individual left the office, did not get her skin cancer removed, and had to find a dermatologist in network, and then wait again for an appointment. So I'm not sure if we're talking about the same person or not. But I think most Iowans, when they hear you'll be able to go to your same doctor, believe you'll be able to go to your same doctor. But what we're finding out is, yes, you can go to your same doctor, but you may be stuck with a bill. Is that correct?
We can't force the provider to participate. If we become aware of the situations and the issues, we intervene as quickly as we can. We have asked if members have issues like that to call our call centers and/or one of the MCO's call centers. And we intervene very quickly with that provider to ensure that they have the information they need to ensure that that member can continue and no cost comes to that member.
So quickly, in terms of allowing that patient to keep their appointment while they're in the doctor's office, or go back through the whole process? I mean, I know getting into a dermatologist is not an easy thing. Are you fixing it while they're still in the office?
If we're alerted to the situation by that provider, yes. As quickly as we can resolve the issues, we are working to get those resolved.
Okay. Then my next question involves a constituent with a very rare form of cancer, has been receiving treatment at Mayo, tried to get more information about whether or not they'd be able to go to Mayo, and we're told they would not be able to go to Mayo. There's no doctors that cover this type of cancer in our area, in our state, And so they sent her to, she basically played phone tag with a number of different places, finally ended up at the rapid response line. Rapid response team, who was told it was on 24/7. She held for 15 minutes. Then they came back on the line and said, whoops, rapid response team doesn't work on weekends. Call back on Monday. And their answer was that she should call Mayo. So I don't know if this is patient-centered, that she should call Mayo and beg them to sign a contract with the MCOs. So is that what we're considering, patient-centered? Having the patient beg Mayo to get their treatment? How are we handling Iowans who have diseases and issues where we don't have specialists in our state to handle them?
If you're referring to Mayo, each one of the MCOs, and I'll let them speak to this, can do a single case agreement for various conditions like you've described with that individual. If you have specifics on that member and we need to reach them and the plans, we can outreach to them, but I'll let them speak to how they're addressing the Mayo issue.
So that's exactly right. We can do single case agreements, certainly for anyone in the treatment zone already with Mayo. We would absolutely honor that and make that happen. It is absolutely not appropriate for a member to do their own negotiation. We wouldn't want them to do that. They shouldn't do that. So that is a great example of how, once we are aware of that case coming in through varying means and how we get case information in, or the member issues in, I will tell you, I will absolutely guarantee we would jump on that. We would put a case management component around that, and we would ensure that we were working to meet that member's needs.
United Healthcare has a very good relationship with Mayo. And when I say that, when we speak about Iowans, we have already actively engaged Mayo to deliver services to one Iowan that we're serving today. And so that is evidence that Mayo is willing to work with us. We will work with them. If there are no specialists, if they are continuity of care, we believe that we'll be able to work with them, and again, we have evidence of already succeeding in doing that for an Iowa Medicaid member we're serving today.
When you say continuity of care, explain exactly what you mean by that.
Mayo has a commitment to continue to provide services to individuals that they have already provided services for. And so that is their intent and definition. From a continuity of care perspective, we have certain contractual obligations here in the state of Iowa for continuity of care, but from our perspective, and then also as we have worked with Mayo, they believe continuity of care is someone that they have been taking care of historically, where they do believe that they would be able to provide the best care for the member.
Okay, so just to clarify, continuity of care, what about a new Mayo patient?
In those situations, if that is the only place and that is the referral for that particular member, we would work with Mayo to accept that case. We would speak with them about the circumstances of the case. In that situation, it would be up to Mayo to decide whether or not they accept that referral. But if they are the source and the experts to deliver that care, we will do what we can do to get that member's care at Mayo.
But I guess, how many doctors does an Iowan need to see to explain no one understands or has the expertise before you're willing to let them go to Mayo for their care?
So first and foremost, it's not let them go to Mayo. What I would say is none of us, I can't speak, I'm not a medical doctor, how many physicians it takes to determine who's the right specialist. But we do have very capable, highly expert providers in the state of Iowa. The University of Iowa is an excellent resource and has a significant volume of specialists. And so as we look inside the state of Iowa, we look to partner with those Iowa providers that deliver that specialty care. And University of Iowa is one of them amongst many that we're working with today. And so we would look to have Iowans seek care in their neighborhoods with providers that could potentially provide that care. If that is not available to them, then we would seek other specialists outside of Iowa if that were necessary. that would be at the direction, again, of physicians, medical doctors, providers that are experts in that area.
Need longer arms. Our situation is very similar. We began working with Mayo even before April 1st. Mayo has agreed to keep all appointments for our members through April while we're working collaboratively with Mayo, with our doctors, our care managers, and with the University of Iowa to help come up with transition plans for members that Mayo doesn't want to continue to see. But Mayo has been very, very good, and we have several members that can continue treatment at Mayo because they are the best facility for that member. The University of Iowa is not always the option because sometimes that's too far away. So they're working with us on when that is a feasible option. When it's not, we look for other services closer to the member that can satisfy those needs.
Okay, and then Mikki, I guess I want to go back to you on explaining the disconnect and how the MCOs said that they would work with an Iowan on making, reaching out to Mayo. They said that they would do it, but then the rapid response team tells the Iowan, you should call and beg Mayo. What are people hearing when they're on the phone, I guess is my question, because I know this woman is quite articulate and intelligent, and I know that she would not be giving me misinformation about her case.
So I need to know which rapid response team. Is it one of the MCO's rapid response teams? We have a member call center. We don't have, in our call center, we don't have that rapid response team. So the disconnect may be which call center she's calling into. And, after this meeting, if you want to, I'd like to get the information to follow up with her directly and to outreach to find and learn about what she's speaking about so that we can correct it and move forward and ensure that there's the right training that we need for this. Because again, I don't know the rapid response team you're referring to, and I do apologize for that, but I would definitely like to get on top of this and understand the issue.
Senator
Okay,
Peterson?
So are the rapid response teams aren't working the weekend, or they are?
Have member call center that does work this weekend. We've worked our member call center for the last 2 weekends. Okay, in addition to that, we have a complex case individual in our member services center that deals with complex cases. Again, I don't know what the rapid response team is, so I'm trying to understand that terminology and try to get my hands on it. The MCOs may have rapid response teams, or they may be using their member services, and that terminology, we may be just crossing a terminology. But again, I'll talk offline if you'd like to, and we'll get to the bottom of this one for you.
Yes, Senator Peterson, if I could, we've got about 6 minutes left, and we have to be out of here by 4 sharp, according to Senator Gronstal. Would it be okay if we took this offline and we could get you in touch? And I'm sure that they would definitely give you the information that you need and connect with your constituent. Would that be all right? Okay. Senator Reagan.
Right. I'll try to make this brief, but Director Street, you may already have this case, but I have an agency in North Iowa that is having some problems getting some of their people that need prenatal visits signed up for those. Their goal is to work with early entry into prenatal care for pregnant women, and their problem is that they get presumptive eligibility, but then they are not with an MCO for that first month then, correct? Tell me if I'm wrong here.
No, you're correct. You're correct.
Okay, so they're trying to sign them up with a provider, and the providers are not accepting them at this moment because they have not signed contract. I know they don't need a signed contract, but they're only doing business with the people they have signed contracts with. So they're having a difficulty in scheduling the appointments. So when then they have to wait till they get their assigned MCO, and if they get one MCO that is not contracted in this area, then they have to wait longer to get that appointment. because it's still, they have to change it for the month, so then there's the lack of services. I know that I forwarded this on to the department, and I'm waiting for a response on this. So I'm just saying that that's really a complication, because we think early prenatal visits are important, and to get this set up as fast as we can would be important. So I would really appreciate somebody looking into it and giving some attention to it.
Yeah, we're working on it. They will be in fee-for-service for any member.
Right, and that's I understand that.
The other
but-
thing is the member can make a choice. So if they want to choose now, prior to their assignment, they could choose an MCO. We can outreach to them, but we will get you an answer in terms of making sure. And we have talked to the 2 MCOs that are involved. They believe in this issue, and we're trying to resolve it and get you a response as quickly as possible.
Okay, because I think, as time ticks away, we could
Yep.
actually, because all the messing around, we could be putting off, really important health care for families. Then the other thing is, last time we had our meeting, all 3 MCOs got up and said, billing is great, everything's smooth, we are having the greatest time. I guess I am just one of those tiny little agencies that, when I go home on Friday and work with that, it is not the most beautiful experience of my life. I would say that it takes me usually one day to work with, and I'm small agency, so I guess that's part of it, but the IL that came out from the department was dated March 30th, I believe. I apologize for not bringing the information in front of me, but I remember it was March 30th. Said to call provider services, which I thought that was an odd number to call for setting up billing, but okay, I went with that. They told me to call EDI. I'd called EDI before because in the past I had worked with EDI because that's where all my claims went. And EDI told me the same thing they told me the time before and said, we're done with you March 31st. You have to go with somebody else unless you want to pay, something for it. And so then I started with the MCO that has the most of my Meals on Wheels people. And I would say that they were surprised at the IL being wrong, which came out corrected on April 11th of new telephone numbers for them to contact, or people concerned about billing to contact. So that's been corrected. And the MCOs were very friendly in dealing with all of them. I can't complain about that. But the most helpful person, which was to my surprise, was the 2 hours I spent with John Joseph in India. And he was extremely friendly and for midnight in his area, but and very helpful. But I was quite surprised that I was dealing with someone when we're looking at Iowa jobs. So just wanted to make sure people were aware of that, and that's another piece of the puzzle. But if you could get back to me on the other one, I know with a short time we'll move on to somebody else, and thank you.
Senator Yoakum, would you like to get one more question in there?
I think I'm going to have to send it to them.
Okay. And Senator Johnson, you were on the list. One quick question.
According to the information I have, and it's dated April 7, what's the holdup in getting Sanford signed up with the MCOs in Sioux Falls? What's the problem there? Avera's on board. Sanford's the other major regional health system, multi-state health system there. What's the deal?
For AmeriHealth Caritas, we contracted with Stanford, I think it was about a week ago.
Anyone else? The other 2 was Sanford? All right, we're going to wrap this meeting up. You can tell there are a lot more questions. I know we'll be in session next week. I don't know what the agenda will look like for this meeting, but if we have a lot more questions, I would encourage that maybe we meet again. This is a critical time. Call volume is high. We want to make sure that people are getting the answers that they need out there. And I think this was a good discussion today. Some of our questions were very specific, but that's what comes into our email. And those are the constituents that need the most help. most often. So we appreciate that. I do want to make one comment. The governor put out a press release, interestingly enough, right before our meeting today, and it says Medicaid modernization means more doctors than ever before serving Medicaid patients. Now, we've been through this again, that we know that we've had one doctor sign multiple locations of treatment. And we understand that. We're not dummies. We know that the billing has to go through where the procedure was done, but it does not indicate that that doctor is somehow 6 different people. That doctor is one doctor. So I just want to clear up any confusion that the governor's office might have about how many doctors we have in the state of Iowa. The annual report from the Board of Medicine indicates there are a total of 11,971 physicians with an Iowa license. Of those, 6,828 have an Iowa work address. The governor's data claims to have 16,821 physicians contracted with an MCO. Could someone at IME or DHS tell the governor's office that we have 6,828 physicians and we don't have 16,821 physicians? If you could, that might cure some of this misinformation that is going out. And with that, Senator Dotzler moves that we adjourn.